Hi everyone again, and welcome back to Oncothon. That's the third year we are convening this Oncothon, the 24-hour marathon. And this year, at February 4, we are united with the UICC on the mission to bring the low and middle income countries transplant programs. And on this session, I have a great honor and pleasure to welcome three distinguished speakers and three distinguished experts from around the world. Professor Fadlo Khuri, the president of American University of Beirut, Dr. Lawrence Faulkner, medical director of Khuri to Children Foundation, and Ikram Esserir, uh, the president of NABD BC2 Association from Morocco. Thank you very much for being with us today.
Thank you.
Thank you. So it's going to be like, I think right now, I was just checking. Thank you. We are, hitting right now more than 100,000 live viewers it's broadcasted on X, Twitter. So we have a huge auditorium right now watching us. And as I mentioned, this year, the team of Oncothon is to bring the transplant programs to low middle income countries. So it's a way of raising awareness and funds to bring these programs to the low middle income countries. I'll tell from our experience, and on this panel, Dr. Faulkner is present, who helped us to set up a program in Armenia, the allogeneic stem cell transplant, and he helps to do this all over the world with the Cure to Children program. Dr. Faulkner, please, can you explore what Cure to Children is doing on that regard?
Okay, thank you.
Oh, and we have Dr. Alberto Costa joining us, the CEO of European School of Oncology from Italy.
Okay. So I will share my screen. Okay. Let me see.
Okay. Do we have that option? I think so.
I'm not sure I can.
I don't think if that's with the slides. Maybe you can just explore it as a panel discussion. With your words.
Yeah, because I don't need the slides. You're saying?
You don't need the slides. I think you have done so many great works in the low middle income countries, so you don't need the slides.
Okay, so it would be more, the format would be more like a panel discussion then. Okay. Well, essentially, so I'm a pediatric hematologist oncologist. My specialty is bone marrow transplantation. I'm the medical director of the Cure to Children Foundation, which is an Italian NGO developed by group of parents that lost their child to cancer, mostly neuroblastoma. And our mission is to expand access to cure for cancer and severe blood disorders directly in middle-income countries, as you explained, Georg. So what we have done in the past is to facilitate the development of the startup of simplified and sort of cost-conscious transplant centers. And our experience now is on over 12 newly developed transplant centers across Middle East, Southeast Asia, and our primary objective has been actually not an oncological disease, but hemoglobinopathies. You know, hemoglobinopathies are probably, as a group, the most common non-infectious, life-threatening disease of children in most of the global, with a global distribution, which is essentially Africa, Middle East, Southeast Asia. So where most of the children of our planet live, and we have overall now 500 transplants, most donors for hemoglobinopathies and also from haploidentical donors. Really, we have not done much unrelated donors for a number of reasons that, of course, we can go into, but mostly because of cost effectiveness. And I think recently, with advances in bone marrow transplantation, particularly the post-transplant cyclophosphamide platform, haploidentical transplants, so partially matched related donors, are probably performing comparably to unrelated donors, but of course are much easier, much more available, and much less expensive. So our philosophy has always been that in most middle-income countries where healthcare is paid out of pocket, cost is a major factor. It's a major, actually, prognostic factor, because if a child with a curable disease cannot access transplant because of cost, that is a cost-related death. And probably is the most important prognostic factor. For example, in India, where hemoglobinopathies are quite common, there is estimated number of more than 100,000 children with thalassemia, and where mortality is still high because the average life expectancy is around 20, 25 years of age. And especially from a matched sibling donor, there is a cure rate now which is over 95%, with most children going back to a normal health-related quality of life. And we know that we can do a transplant in India for a cost that is in the range of $10,000 to $15,000 for a match-related transplant. Probably for a identical transplant will be in the range of $20,000 to $25,000, which is, of course, much less than in Europe, US, but also in other countries. And so also, we have tried to stress that the most important variable in setting up a transplant center really is the nursing team. People think that you need very expensive, complex air filtration systems, and that are very expensive, especially in middle income, hard to maintain. But really, what now makes a huge difference is your nursing staff. And so we have really invest mostly on nursing, on training nurses, because at least in our experience in India, most of the complications and deaths related to transplant are really due to antibiotic resistant germs, not so much now to viral reactivation or fungal diseases, because especially for hemoglobinopathies where children have not received a lot of chemotherapy, they reach transplant with a good count, good general condition. The period of neutropenia is relatively short. So the problem is really the management of the second line, the proper administration of chemotherapy, the proper monitoring of the patient, and so that is, of course, mostly related to nursing. We also have a lot of emphasis on data management, online advice and consultation, and also on quality assurance, so more than on fancy, complex transplant centers. And to the point that in a center in Bangalore, which again is performing transplant for $10,000 to $15,000 per transplant, we are now undergoing the FACT-JC accreditation, which is the top level international accreditation for transplant centers. The last thing I want to say is that we set up a simplified transplant unit for children, for low risk children, particularly for hemoglobinopathies. We can probably do it for something in the range of $70,000 to $100,000, which of course is much less than most people think. And so I think I gave an introduction of what I'm doing, and so I'm I'll be happy to answer any questions. Yes.
Thank you very much, Dr. Faulkner. When someone speaks about the transplant programs, first of all, you come to my eyes because you were the one pushing us back long time ago that it's possible to do transplants. You don't need a lot of money, and it's going to happen because your philosophy that, with setting up transplant centers with limited resources. Just imagine, to set up a transplant center from $70,000 to $100,000. It's amazing, and decreasing the price of transplants to 20,000, 15 to 20,000. It's amazing, and thank you so much for helping us and making this happen. So certainly, I mean, if anyone asks my opinion, your model is the model to go for the whole world, and I mean, this is like an example for me. Thank you very much.
Thank you.
I'd like to ask Professor Fadlo Khuri, the president of American University of Beirut, is a very well-known cancer physician scientist who has done a lot in the United States globally. He was also the editor-in-chief of Cancer, and then he came back and is leading already many years. He's leading one of the top institutions, not only in Middle East, but globally, American University of Beirut. And Professor Khuri, I'd like to ask specifically about how you are navigating the cancer care for displaced populations. I know you are doing so much on that regard and helping so much to the refugees. And American University of Beirut and its medical center, and specifically its pediatric cancer center and adult cancer center, are really like a top-notch and doing so much in the region. Please, can you explore about this and on your vision on how we can make equitable cancer care for refugees?
Thank you
Please,
very much.
Can you turn off your microphones so that it does not echo?
Yeah, I'll wait for Lawrence to turn off his mic. Yeah. Okay, can you hear me? So, Kevork, thank you very much for inviting me. It's a pleasure to be with you. This might indeed my 11th year as president of AUB. I was for many years in the US, 20 years between MD Anderson and Emory. And even there, I learned some lessons which are very applicable to this part of the world. I'm going to talk specifically about cancer care in the Levant, Lebanon, Syria, Jordan, Iraq, Palestine. So if you talk about the Levant, there are really only 3 places that do allogeneic transplant, and all of them started in the 90s or 2000s. The first, of course, was AUBMC. The dean at the time recruited Ali Bazarbashi, who was a brilliant young physician scientist from France. He is in 96, 98, he established the bone marrow plant transplant unit, 2004, the inpatient unit. And now Maqasid also does that, much smaller volume. We've done 1,700 transplants. We're starting to do CAR T cells here. And then the King Hussein Cancer Center. And that's it for allotransplantation for the people of the Levant. There are, of course, small centers, even in Syria, that do some auto transplant. But, it's worth reflecting now when we see these very encouraging statistics from the American Cancer Society that came out last month that show that 70% of people with cancer who are diagnosed with cancer are alive 5 years later in the US. And we're curious, of course, that data will come out in 2 or 3 years from IARC, ICC, and others about the rest of the world. So in this part of the world, you're challenged with access to care, you're challenged with resources, but you're also challenged to keep learning. And one of the lessons is about leadership. So from the beginning, AUB has supported, and I've been on the external advisory committee for the Naif Khuri Basil Cancer Foundation and the Cancer Center for now 22 years, well before, back from when I had just left MD Anderson, moved to Emory, about how you grow an institution. You grow it around leaders in nursing, leaders in medicine, leaders in supportive care, transplantation, social services, because the reality is that in this part of the world, with access to care, and finances are both a challenge, then you need to, first of all, sell the care to a patient population that is not even used to being told until maybe a decade or decade and a half ago that, no, you have cancer, Mrs. and Mr. So-and-so, and for that we need to treat you. And second, understanding a way to deploy limited resources as efficiently and fairly as possible. And this was particularly challenging in this last decade in Syria and Lebanon, now Palestine, because of the collapse of the economies, of security, of the state in so many ways. Now that Lebanon's state is coming back, and to some degree Syria's, we're seeing some important steps. One of the important steps it starts with is data. So we always try to work with everyone. And I'm just coming straight from a celebration of World Cancer Day at our Cancer Institute at the American University of Beirut with the Minister of Health, who's our 3 times graduate, undergraduate, medical school, and residency in vascular surgery before he did his subspecialty abroad. And data suggests that how do you gather data in much of the world? Well, it's not population-based, it's data registry. Where do the data registries come from? They're skewed towards hospitals and health systems, right? Because it's hard to get the data in Syria and Palestine and Iraq, even in Jordan on the population level. Theirs is probably among the best. So getting the data to know how many cancers we have, how we allocate our limited resources there, how we wire in, sort of network in the physicians, the societies, the universities, so that they're not only involved in the theoretical care of the patient or the care only the high-end patient, but patients in the community is an ongoing and extremely interesting aspect of cancer care and cancer research. So as you indicate, Gevorg, I've gone from a clinical trialist to a translational researcher to more of a biologist and a cancer biologist and a leader, till you get more involved in things that involve the population health, public health, things like pushing smoking cessation and smoking prevention on our own campus and across the university system. These things make a difference. So it's an ongoing uphill struggle, but a very meaningful and important one.
Thank you so much, Professor Khuri, and I'd like to thank also you for the work the Children's Cancer Center of AUB is doing. I'd like to reflect on, we had the privilege of hosting the team. It was, I think, 8 or 9 years ago, of the AUB nurses. They came to Armenia, they shared their experience with our nurses, and it was a life-changing experience for our all nursing staff. So it's like, certainly AUB is one of the stars in low middle income countries, not only in cancer center and medical education, but also equitable care. Thank you very much for your leadership.
Thank you. Can I reflect on that for 30 quick seconds? So again, that teaches us the same lesson, not to be arrogant. St. Jude's decided to partner with Lebanon because St. Jude's has a very heavy Syro-Lebanese origin from Danny Thomas. AUB recruited Miguel Aboud, world-renowned for his work in sickle cell diseases, to head the St. Jude's Center. Philanthropy came in. Philanthropy is so important in our part of the world. And as a result, we transplant children and adults. We treat people for free, like St. Jude's, with children's cancers and children's diseases. And going to refugee health, to answer your question, we treat the majority of Palestinian refugees with sickle cell disease in the country. And we do it without putting a huge bottomless hole in our budget. And this is the kind of thing that one can be very proud of. And I'm honored that in Armenia, you would look to us to in any way help. And that leadership starts, you're right, at the nursing level, at the physician level, the patient advocate level.